In this video, we'll explore osteomyelitis, covering its classification, epidemiology, pathophysiology, and historical development. Osteomyelitis is a term coined by Neleton in 1834, derived from Greek root words, osteon meaning bone, myelo referring to marrow, and itis indicating inflammation. The term describes an inflammatory process involving bone and bone marrow, highlighting the involvement of both cortical and medullary components of the skeletal system. This condition represents a pathological response of bone tissue to inflammatory insult, most commonly of infectious origin. The nomenclature itself underscores the anatomical extent of the disease, as inflammation is not limited to the bone surface, but extends into the marrow cavity. Osteomyelitis remains a significant clinical entity due to its potential to cause structural damage to bone and long-term morbidity if not adequately managed. Osteomyelitis may be classified based on age group, duration of symptoms, route of infection, and causative organisms, each of which has important clinical and pathological significance. According to age group, osteomyelitis is classified into neonatal osteomyelitis, occurring in infants less than 2 months of age, childhood osteomyelitis, seen between 2 months and 4 years, and adolescent and adult osteomyelitis, affecting individuals from 4 years through adulthood. Based on the duration of symptoms, osteomyelitis is classified as acute when symptoms are present for less than 2 weeks and are associated with sudden onset and marked inflammatory response. Subacute osteomyelitis refers to symptoms persisting for 2 to 6 weeks, typically with milder systemic features and localized disease. Chronic osteomyelitis is defined by symptoms lasting more than 6 weeks and is characterized by persistent infection, necrotic bone, and sinus tract formation. According to the route of infection, osteomyelitis may be hematogenous, where infection reaches the bone through the bloodstream. Direct inoculation, following open fractures, surgical procedures, or penetrating injuries, or secondary to adjacent infection due to spread from nearby soft tissues or joints. Based on the causative organisms, osteomyelitis is classified into pyogenic osteomyelitis, caused by pyogenic bacteria producing acute suppurative inflammation, and granulomatous osteomyelitis, caused by organisms that induce granuloma formation, such as tuberculosis or fungal infections. This classification provides a systematic framework for diagnosis, assessment of disease progression, and formulation of appropriate management strategies. According to the Peltola and Vavanen criteria, the diagnosis of osteomyelitis is established when any 2 of the following 4 criteria are present. These include pus aspirated from bone, which provides direct evidence of infection. A positive bone or blood culture supports the microbiological diagnosis. The presence of classic clinical features such as localized pain, swelling, warmth, and limitation of range of motion of the adjacent joint reflects active inflammatory involvement. Finally, radiographic changes typical of osteomyelitis further substantiate the diagnosis. The fulfillment of 2 out of these 4 criteria is considered sufficient to diagnose osteomyelitis in a clinical setting. The epidemiology of osteomyelitis shows variation with age, anatomical location, and microbial patterns. Staphylococcus aureus remains the most common causative organism, responsible for approximately 40 to 90% of cases across all age groups. Osteomyelitis most frequently affects the lower extremities, accounting for nearly 70 to 90% of cases, reflecting the vulnerability of long bones to hematogenous spread and trauma. Among joints, the hip is the most commonly involved, with an incidence of about 54%, particularly in pediatric and adolescent populations. Recent epidemiological trends demonstrate an increasing incidence of methicillin-resistant Staphylococcus aureus, MRSA, both in community-acquired and hospital-acquired infections. This shift has influenced disease severity, treatment response, and antibiotic strategies. Overall, osteomyelitis continues to represent a significant clinical problem due to its predilection for children and adolescents, its tendency to involve weight-bearing bones, and the evolving pattern of antimicrobial resistance. In children younger than 1 year, staphylococcal species are the predominant cause of nosocomial-acquired osteomyelitis, while group B streptococci are responsible for many community-acquired infections in the neonatal period. In the age group under 5 years, the most common pathogens include Staphylococcus aureus, Kingella kingi, and Streptococcus pneumoniae. It is important to note that the incidence of Haemophilus influenza type B infections has decreased substantially due to widespread immunization programs. For children older than 5 years, Staphylococcus aureus remains the primary causative organism. In sexually active adolescents, Neisseria gonorrhoeae should be considered as a potential pathogen, especially in cases of osteomyelitis or septic arthritis involving the pelvic region. This age-specific distribution of causative organisms is crucial for guiding empirical antibiotic therapy and optimizing clinical outcomes. Pathogenesis involves a complex interplay between microbial invasion and the host's immune response. The infection usually begins when microorganisms gain access to the bone, most commonly through the bloodstream, which is typical in children. In them, the metaphysis of long bones is particularly susceptible due to the slow-flowing sinusoidal capillaries, which allow bacteria to lodge and multiply. In adults, however, the infection more often arises through contiguous spread from adjacent soft tissue infections or direct inoculation following trauma or surgical procedures. Rarely, it can result from vascular insufficiency, as is often seen in diabetic patients. Once the bacteria reach the bone, they adhere to the extracellular matrix and start multiplying. Staphylococcus aureus is the most common culprit because it produces adhesins, toxins, and biofilms that help it evade the host defenses. The host immune response triggers inflammation, edema, and an increase in intramedullary pressure. Ironically, this immune response, combined with the rigid structure of bone, leads to compromised local blood flow, causing ischemia. This ischemia further favors bacterial survival and hinders immune cell access. As a result, segments of bone become necrotic, forming sequestra, which act as protected niches for bacteria, making the infection persistent and difficult to eradicate. The periosteum responds by forming new bone around the necrotic segment, called an involucrum, which is characteristic of chronic osteomyelitis. Over time, the chronic infection can lead to sinus tract formation, fibrosis, and even pathological fractures. Essentially, osteomyelitis represents a tug-of-war between invading bacteria and the host's immune system, with a confined environment of the bone and impaired blood supply often tip the balance in favor of persistent infection, unless adequately treated. The history of osteomyelitis typically begins with localized bone pain, which may be constant or worsens at night and can be associated with movement. In children, refusal to walk, inability to bear weight, limping, or avoidance of using the affected limb is common, while adults may report difficulty with weight-bearing or functional use of the limb. Systemic symptoms such as fever, malaise, fatigue, and anorexia may also be present, reflecting the ongoing inflammatory process. A recent or concurrent illness is often noted, as hematogenous spread from infections elsewhere can predispose to bone infection. Local trauma, surgery, or invasive procedures may serve as portals of entry for bacteria. Recent antibiotic use can modify the presentation, partially suppress symptoms, and affect laboratory results. Underlying conditions, including diabetes, immunodeficiency, or sickle cell disease, may increase susceptibility and influence the course of the infection. Thank you for your time and interest. Please consider liking the video and subscribing to the channel.